Okay?
Right.
So, this is about my journey in the fight against liver cancer through the world that I've become part of, which is interventional radiology. And I'm an interventional radiologist. And you gotta ask that question, is where did this start? Where did the journey start? Well, of course it starts when you're a little kid. And I grew up in an Indian, very, strict family where, my mother, my father actually died when I was quite young, but my mother became the patriarch. And there's some things that are common about Indian mothers. The very strict nature, and that face is very common. And the other is the stick. And the other third thing about Indian families is, you must be a doctor. But, I was a bit of a rebel, and I knew where to hide. It's a facsimile. And I was stubborn, and I said, no way am I going to be a doctor. No way. Absolutely not. My life was mathematics. And you would say, mathematics? How can I be interested? Mathematics is what we are doing all day, every day. And in my senior year, I actually started to work with a computer called Commodore 64. And
You're dating yourself.
And this brought me into the world of scripting and programming, and I was taking these type of programs and programming them in how to play myself. In other words, I'd be playing the computer, and I would write that script, and I loved it. Take the computer home every weekend, and so on. Well, this is indeed what I do. But in my senior year, my mentor in mathematics came to me and said, in grade 12, said, you know what? There's this big, beautiful world going to happen. And it's this place called Silicon Valley. I said, Silicon Valley? What's that? And that was 1979, where this guy just got out of jail, which is Bill Gates. And of course, 1985 is when the first Windows version started, right? And these two, Wozniak and Jobs, actually started out in 75 and were looking for computer programmers. And I said, why would I do that? So, which do you think I'd play better? So I went on to my career in mathematics at Dalhousie. And, God love them, at that time, there wasn't anybody there that was really excited. And I sort of got a little disenchanted, a little disillusioned. And I said, oh, maybe I'll go on to become an actuarian, which is a mathematical genius, which I'm not. And in fact, that mathematical genius who I went to talk to said, you know what, this is a pretty hard slog, and I'm not sure you're, essentially in his own words, said, I don't think you're up for it or capable of it. And I think you should think of medicine. I said, medicine? Why would I do medicine? And he showed me the path, which was this whole idea of bringing mathematics into the business of helping people. Research, designing, and tinkering, and all my world is problem solving. And the mathematics is key to all of that. So I went off to medical school. Got a little disillusioned in medical school too because I couldn't find my path. Till one day I saw this. I came in to the dungeon at that time with my patient. And I was on internal medicine service, and the patient had short of breath and had a pain in the chest and was due to a clot in the lung. So I walked into this dungeon, and this guy looked like he hadn't seen somebody for years. He just took me in under his wing. And he was an interventional radiologist. He said, where are you, and talked to me, and he said, come and see this. And he took this little catheter into the groin, like a tiny little nick, and he took this little tube, took it up through the heart. I don't know if this laser pointer will work on here.
No, it disappears.
So what I'll do is can you see a mouse here?
Yeah.
Yeah, so coming up through what we call the right atrium of the heart, through the valve, into the right ventricle of the heart, up through what we call the pulmonary artery flow tract, into the pulmonary artery. And he started to inject this agent that breaks up the clot. And the patient's symptoms are getting better. And I'm thinking, holy crow, this is unbelievable. Here's this guy in this phenomenal looking room, which is an interventional suite. Monitors like that, I felt I was at home. I said, I could do this for the rest of my life. And so hence my embarking on this world of radiology and interventional radiology. Other parts of this is, here are the catheters we use to get places. And you know, they got the coolest names. This one up here is a Cobra catheter. This one's a headhunter. This one's a shepherd's crook. This one's a sidewire. I mean, cool names, what else? And we in interventional radiology touch every part of the body. And we have to understand every disease process and everything that goes wrong, because we can be involved in the care of that disease as such. Here's a little animation going into the groin. Again, queasy. So here's a catheter going up. This is what in fact, I trained in neuro and peripheral vascular interventional radiology. Going all the way up, around the heart, up into the neck, up into the brain. And we do this on a regular basis to go and treat something like the aneurysm you'll see here. Using that same IR suite to these sort of maps of the arteries with X-ray as such. So these are our maps, and what we do is then find our way through those sort of pathway of arteries as such. So again, the difference between a PlayStation and this is $2 million. And the reason it's $2 million is because it can do things like that, which is to do a mini CT scan or position the tube in a way like that, in many different angles. So what that does is, using X-rays you see up on the screen, shows me different ways to look at the body while I'm doing a procedure. Sort of follow that? Any questions up to that? So where can we go in? We can go in at the groin level, into the artery or the vein, and here's a spot where, here's the hip, here's the groin artery, we get in there, and as Hilda will tell you, should I say, was it painless? Did you remember even me being?
Oh yeah, I remember.
Yeah.
It wasn't, it was painless.
There's a story about Hilda where I didn't realize who she was. Every patient's important to me. But obviously you're very special in our community. And I only found out about him after the first procedure, where I was, finished. Yeah. And you said, "Isn't there somebody here?"
I was texting, Matt and I were texting back and forth. He said, Hilda just got out of the OR, and I had been chatting with Bob back and forth, so I sent Bob a text, by the way, Hilda's out of the OR. He said, "That's good, I'm sure she'll be fine." But he didn't say until he walked out of the room.
Yeah, then I heard.
Whoa.
So, anyway, we can also go through what we call the radial artery. It depends on the patient, it depends on the situation, and what we're trying to do. Here's some examples. So what we do with arteries, for example, I can open arteries that are blocked. I can shut them down if they're bleeding. I can go on and on. I also do a lot of venous work, but I also do work in the organs, such as the liver, spleen, the kidneys, the lungs, you name it. And of course in the brain and so on. Here's an example of, this is normal artery anatomy to the lower limb. And there's a significant number of patients who end up, because of diabetes or because of bad hardening of the arteries and such, to get blockages. Blockages can result in not enough blood getting to the tissue, and if they hurt their foot or so on, a little sore forms that's not going to heal. And that could become infected, and then they lose their leg. So those patients will come to someone like me, and what we do is, here's an example. Here's the left leg. I know it's on the right side of the picture, but it's because the patient's lying down. That's the left leg, and that's a relatively wide open artery with X-ray data. You can see that's not the case on the right leg, where there's a complete blockage from here to here, causing not enough blood to get to that sore to heal. And so what we can do is go through that area of blockage or the plaque that you see here, and here's an example at the level of the knee, me going down with a little catheter, and this one was a slightly bent catheter called a Davis, and a glide wire. And what we can do is we can try and find our way into it. And again, I have a bit of a map or an understanding where I'm going. And then what I do is essentially push the catheter and the wire through. And then we put a balloon in place. And here's me going down even a longer occlusion right down to the foot. And in fact, I've gone down to the foot and all the way back in some of our patients. In the last 10 years, the revolutions in what we can do has been incredible. And then we can put a balloon in to literally break up blockage or the plaque that's causing the neck. And if the balloon itself doesn't work, we can leave these metal devices called stent. And you'll see these because I'll hand them out or we'll demo them here. To keep the artery open. And so what you can do is take this sort of scenario where this is the level of the knee. This is one of the arteries that's blocked all the way from here to here. And then we get through it and put this is the actual balloon filled with X-ray dye that's inflated. And then afterwards you can certainly see about a road that is allowing blood to get down to the foot. So what about aortas, or what we call aneurysms, where the wall of the artery starts to weaken? And I think all of us have heard of patients with aneurysms. One of the big arteries that becomes aneurysmal is in the belly as such. And that's just below the kidneys. And what can happen is when there's a weakening on a wall, over time, I mean years, the whole vessel starts to balloon out. And if it gets to a certain point, usually 5 centimeters, it's at high risk for rupture and death. So, 2 ways to treat that. One is surgery, where they take you stem to stern, open you up, and put a tube graft and sew in the graft. And they sort of exclude that aneurysm. Or, instead, you can have 2 little incisions in the groin and put this device in and treat from the inside out, like this. So that's a wire going up. This is the device. There's the aneurysm. You can see the ballooning. And then we deploy this device from the inside out. And that's called a stent graft. And the fabric or cloth is the same as the surgical graft that they sewed, except it's on these metal devices called stents, which we talked about. And instead, we can treat from the inside out rather than from the outside in. There is actually a video where the patient, under local anesthetic, has this procedure done. They finish the procedure, they finish the closure at the groins. He sits up, gets off the table, waves, and walks out the door. It's unbelievable.
I want to read that.
I looked for the video on YouTube, couldn't find it. What about the jugular? We go for the jugular a lot. The jugular is a place where we can do all kinds of things. And here's an example. Remember that clot we were talking about in the lung, in the pulmonary arteries and such? Well, if it's big, we'll go after it and use that clot-busting agent and things like that. But when it's small, usually it'll go away with time, as long as more clot doesn't come to it. So you either go on a blood thinner, well, usually you go on a blood thinner to keep the clot from forming and going and making it worse. But some patients can't go on the blood thinners because of bleeding, for example, or a risk of it. So they call me. What do? I go in from the jugular, or sometimes from the vein in the groin, usually the jugular. Come down through the heart, down to the little part of the belly. What I do is I leave a little filter. And here is the filter being deployed. And you'll deploy, or you'll see it, the filter being deployed. And that filter just catches any clot and protects the lungs. Okay? A few weeks later, if the patient's bleeding stops and they go on blood thinners, they call me again. And they say, can you take that out? Sure, I say, and I go fishing. Come from the jugular, and you'll see a little device. There's a little hook on that filter. I grab the hook. Anybody getting queasy? And then, once I've hooked it, it's nice and stable there. I take the sheath and I collapse it down and take it out. Painless too. A little bit of local anesthetic, a little bit of sedation. The patient says, you're done. You know what, for time, we may not, it's just with the jugular, you can do other things with patients with, liver disease, and they have what these things called varices. I don't know if you've heard of them, they have a lot of bleeding. It's because of the amount of pressure in the veins going to the liver. And these veins need to be sort of relieved of pressure. And one way to do that is, so there's that vein going to the liver that has high pressure. Surgeons can go in and put a tube graft surgically from this vein, that portal vein, to the liver, to this systemic vein, or we call it body's vein, called the inferior vena cava. And what it does is it allows all that blood pressure to dump into the normal circulation. The problem is the death rate is around 70–80%. So instead, they call us. And what we can do is we can go from the jugular again, we go through the heart, down into the liver, and then we literally drill a hole between the vein that's going up to the heart, right up here, sorry. It's not right in the heart's up here somewhere. From here, through the liver, into this vein, and we create that same surgical conduit. Instead of doing it by surgery, we do from the inside out, same idea as a stent graft for the aneurysm. And we all of a sudden allow that blood pressure to be relieved this way. And that's called the tension or intrahepatic course stent shunt, nice fancy name. Or TIPS, we call it. And just to show you, here's a queasy. Anybody queasy? Thank you. How do you do? So here's the catheter through the jugular, through the heart, in the upper part of the liver, in that top vein. I need to drill through the liver to get into the portal vein. There's a little marker where the portal vein is. And here's my needle. I'm trying to find my way down. And eventually, and this is, it's taking a few tries. This is the one that works. You can see that I hit, or we hit, right on spot. Once we're there, we send a little wire through the needle into that vein. Once we've got the wire down, we place the stent. You can just see the bottom of the stent here. Now watch what happens when I pull the coverage of the stent off. You'll see it open up. Do you see that? Kind of, it's like a little bit of jewelry there that just opens up. And you'll see it. I'll show you what they look like. And what that does is holds the track open that I've created. So there's the track we created. This is after the stent's in place. You can see the blood, which is the x-ray that going all the way up through the shunt up into there. And all of a sudden, those varices, or where it's bleeding, the pressure in them suddenly drops, and the bleeding stops. Life-saving. A lot. I know. Sorry if it's getting, I'm hoping you're following it.
Oh, yeah. No, very good.
Okay, here's again another area where I got a lot of, obviously we'll see because of where I've gone with the research. It was embolization, fancy name. Essentially I'm blocking arteries. Blocking arteries, why would you block arteries? So if I get called at 3 in the morning with a trauma, or one of some of my most memorable moments are patients who've just had a child and the placenta's bleeding and they are afraid to operate because they may kill the patient. They'll call me and say, we've got a bleeding situation, we need you to help. So when we go down, we find the artery that's bleeding and we block it. And I'll show you the different ways we can block it. The other thing we can do with blocking arteries is to starve blood from tumors. And essentially they starve to death. If they don't get enough blood and they don't get enough nutrients, and so the tumor starts to shrink and die. So how do we do this? There's 4 different ways, really. More than that, really, but in general. One, you can inject these little tiny particles of spheres. And the spheres can go in and they penetrate deep. And they're usually what we use for treating tumors, because we get right down into the tumor. If we're dealing with bleeding or hemorrhage, we can use different things such as plugs like this and put them in, deposit it and stop the blood flow. Or we can use little metal coils. And you'll see these coils as we deploy them here to treat the artery that might be bleeding, or an aneurysm that's off the side here like that, that's bleeding. We can actually use crazy glue too. Take the crazy glue and I mix it up with a little bit of oily contrast agent and I pull it together and I see how sticky it is. When I have it right, and sometimes, yeah, I get it right. When I inject, the little liquid glue goes in, gets into the little arteries that are in this kind of a tangle. And they sit there and they become cement. Same, it's literally crazy glue. It's got a fancy name because it's a medical crazy glue. It's crazy. So coil embolization, here's an example of bleeding from an ulcer in the bowel, in the stomach area. This is my catheter in what we call the celiac artery in the upper abdomen. There's a little micro catheter. You see this little dot? So this is my big catheter, this is my little catheter going all the way, and there's a little dot. This is the coil. Now watch me go. Going all the way around all of those tortuous paths, and once it's out, it forms this little coil with these little fibers that form a clot, right where I'm wanting to stop me again. Okay? Little animation of a aneurysm in the head and how we treat that with coils. You can see the coil going up and it just fills the cavity. And again, the fancy PlayStation or Another area where you're going to hear a lot more, and you may have heard in the last couple of years, is the treatment of sudden strokes. If we can catch a patient within 4 hours, we can now treat these patients who, when they walk into our room, they can't speak, they can't move their heads. And when we're done, they're looking at us and talking to us. How do we do that? It's called, there's different terms for it, but it's an aspiration thrombectomy. Fancy name. Aspiration is on sucking. Thrombectomy is thrombus is clot. And the ectomy is on taking it out. And so if you've got, and remember, so we got a crew of people. I'm a peripheral interventionalist, I was trained in neuro, but we also have neurointerventionalists. And in many centers, the peripheral interventionalist is doing a lot of neuro work and so on. But if you take this clot that's in this artery to the brain, such as that, this is the kind of scenario that we have. So same sort of a thing, clot up into the artery to the brain. So we got to get through the clot first. Okay, get a little wire across, and we put a catheter across, nice and slow, so we don't dislodge the clot. And once we get there, we put this little device, like a stent, except it's different. And then we pull the catheter back to let that device deploy across. Then we go down, we sometimes inflate a balloon in the carotid to protect here. And then we take the clot out.
What? That's so easy, I could do it.
Yeah. I can guarantee you. Remember, I always consider myself the monkey that was playing the video game. Because literally, the stuff that I do is not. The issue is you got to know what you're doing still. And that's where I guess my own keep, which I don't like to do too often.
Tree of those Steve.
So let's do some demos, huh?
No.
Now I gotta have my kids do at least 1 or 2 of these, if they're okay with that, and then we'll get, you know what, let's start with balloons to keep people going fast.
Okay, John, could you lay on the table here?
So these are angioplasty balloons. These are all expired, can't be used products, so this is not a waste. And this is thankfully due to a great company called Cook. But there's also other companies' products here. So this is the catheter. This goes over a wire up to where there's a narrowing. Oh, you know, there's these little green things that if you see it, take them off. The balloon is on the end here. All you have to do is squirt and you'll see the balloon go up. We'll start one that way and then work you this way. Wait, is it working? Yeah. Now, so there's different sizes. That's a smallish one, right? That's like, it's probably 3 millimeters or something. They go up to 16 millimeters, right? Or in fact, I should say even larger. But yeah, just feed it through. Just take that.
That's an idea.
Now,
Bob
You
make
can
a
feel
balloon
it.
animal.
That's what he does. Bob, we had a request. We had the church picnic on Sunday, and we thought that this would be good for making balloon animals. Wasn't me that suggested it.
Wasn't me either.
You're the one that said it.
So do you want to, I don't know if you want to gather around this one?
Now you said you fixed things well.
Yeah.
I kind of broke your.
Is it a little
I'm a push on that
metal run.
Is what?
Just need a new syringe.
Oh, it's on rotors.
No, I just straight up broke it.
Oh, you mean because it fell off.
Bring it back a little bit.
What field is Nikhil going into?
Just hold it.
Yeah.
Okay, don't give it to me.
Yeah, just, I think it should be, you should get a feel for it. So put your fingers on the balloon and feel the pressure of how much is in it. What? You just pull, oh, sorry. When when you inject in, you'll inflate it, right? And then you can just aspirate in the back. And then it gets deflated. Okay? So you want to come and deploy an IBC sensor?
Yes, your only answer.
So if you want, if you folks want to just gather around and then we can, usually you get it first time, but.
You would get it the first time.
Sorry about that.
So when you're in place,
Press the red button.
press the red button first, okay? Now just watch everybody's eyes, just in case it... Yeah, now press the... Thank you. There it is, and it's off. Now the ends are sharp, okay? So just hold at the hook, and you can send that around. Okay, so yeah, please don't assume you should open your fingers. So that's an umbrella. So the idea is it's sitting in the vein like that. And so it picks up clot. And the clot sits in here, and the body gets rid of it at time. If I need to take it out, there's the hook. You saw me grab it.
So the body dissolves the clots.
It's its own clot. You have a natural, what we call fibrinolytic system. It breaks clot. And it knows clots there, and goes and attacks it and dissolves it.
So how are you seeing the specific detail of this? How is
That's
it?
great.
Gee,
Yeah, just watching it, the same thing as you saw up there.
yeah.
Is that a big,
Dye?
like a big screen
And the
TV?
X-ray dye to show me,
Yeah.
like, you know, what the vessel looks like. But most of that is just done by,
You ever have people react to those?
no, not to those.
No?
They have had some issues recently that there were too many being put in for not as good a reason.
Right.
They're really great, but because they have complications, let's say, and I've always said it's because they've saved their life, that it can get filled with clot,
Right.
right? But with that, all of a sudden that big vein that's draining all the blood, suddenly you get big, big legs because there's all the blood has nowhere to go. And so, you know, there's been those kind of concerns.
You
and
solve
in fact,
one
the health-
problem, create
That's right.
another. but-
Yeah, so
yeah.
you have to be very judicious as to
Right.
who needs this.
Yeah.
What about perforating the artery when you're...
Very rare.
Oh, very rare?
Very. Now, that's a good point. You mean with time? Yes.
No, when you're putting that through.
Yeah, so for us to do it is very rare, for us to cause a problem. But with time, those sharp bits
Yes.
start to break through the wall. But do they cause a problem? No, because it's doing it slowly. But the only problem is they can go out and get stuck. So it becomes very difficult for us to get out. We still usually get them out. If we need to. All right, Zoe, good job with the IBC filter. Could you give me a syringe and that orange Nikio?
You want to break something else? Sorry, I couldn't resist.
Where do I lay on the table?
This won't hurt a bit.
Yeah, I've heard that before.
So there's a lot to this thing.
Wow.
Can you hold that thing?
You say
Oh, sorry. Yeah, that's good. This is sharp, so just, Zoe, can you take this?
Ow!
Give him a little jab.
Yeah,
Looks like a hairy
poke me in the neck.
Take this off. Okay. Where's that? Oh, the orange cloth.
It's amazing.
Did you practice this at the Nikio?
You practice on me.
You used to be good in school, not so much anymore.
I was sick because of them a lot of times. Oh.
No, still.
That's why it's expired.
Okay, so remember that aneurysm in the body? Remember you were going to treat the aneurysm from the inside out?
Right.
What you're going to do, just take this off.
Have you done this before?
So take your hand like that.
Okay.
You're going to hold the gray.
Right.
With the right hand,
Yeah.
or you can do it this way, whichever way. But you're going to pull this back over this.
This, right
Yeah,
here?
on the gray. You're going to hold the gray.
Oh.
Pull
the black down.
Pull this back.
This right here?
Yep. Pull straight back, nice and slow.
Whoa. Wow.
Right. Now take this lock off. This lock.
How do I do that?
There you go. Very dry. Yeah, not gonna work because it's expired.
Wires coming out everywhere.
Are they reusable after a while?
I should hold the gray. Okay? And just take that one off. Okay, same thing. This time, I want you to hold the gray, and from here, push the metal.
Push it in.
Yeah, nice and slow. Is it working?
Yeah.
Do it again.
Doing it, no resistance from the body.
That's not exactly.
Ah,
So that's what hooks into the vessel. Then
Wow.
again, sharp. Oh, this one's.
Yeah, there's one there.
So watch your fingers on here because these little hooks are sharp, so you can hold it here without any problem.
So this is what gets left behind.
That's right. It's in the patient.
that big. What's that made out of?
So this is Gore-Tex or PTFE is the type of material, depending on the company.
Right,
And this is all stainless steel
Right.
or titanium.
So how big would the artery be that goes
Because
in?
it wouldn't be that big. in the artery.
So it's about a 3 centimeter at most, or a 2.5 centimeter aorta at the top. But the aneurysm might be this big. So the idea is where
Right.
the artery
The
is
aneurysm.
normal, it's holding like that and
Yeah.
sealing. Then the aneurysm comes, and then here it's going to be normal.
So the aneurysm would be that big, though.
Oh, the aneurysm could be much bigger, yeah, itself, yeah. We've done sort of 8, 9, 10 centimeter aneurysms, yeah. Yeah, so you can.
How do you detect, don't aneurysms just happen and it's too late? So how do you detect
Usually,
it?
if you've got a family history, your doc should send you in for an ultrasound.
Yeah.
And if you don't have a family history, yeah, it's, you suddenly feel there's something there, or there's a little, what we call pulsatile mass, yeah.
Wow.